Yep, got it. Well, okay, guys. So this is a presentation on patient-provider communication, going beyond the differential. So I really want some feedback, some interactions. I don't want to just talk. I really prefer not to. So with that said, here are the objectives. We need to understand the link between compliance and communication and patient outcomes. Dr. Hayes, I'll send everyone a copy of the presentation.
Oh, thank you.
The goal is to demonstrate the importance of knowing support services, because as physicians, I feel like a lot of times we don't know all of the patient support services that are out there that can help our patients be more compliant. So we'll talk about that and really easy, free ways that you can get these resources to them. Understanding the importance of health education and literacy. And then the last goal is to teach physicians how to maximize the support for patients' compliance. So we're going to start by talking about the HPV vaccinations. What do you guys know about the HPV vaccination? What's the guidelines for it presently? I'm actually talking to the room here. What are the guidelines for getting the HPV vaccination presently? Giorgio, Dr. Hayes, Dr. Stein?
And, I know the European guidelines. I don't know the
okay, so what are the European guidelines?
Basically, it's not compulsory, but it's suggested to every adolescent, and it's free for every teenage girl under 18.
So after 18, they're not allowed to, you're not to give the vaccine?
No, I don't remember the threshold, but yeah, usually it's free for teenage girls.
Okay, so in the United States, the guideline is basically that you want the patient to take it as an adolescent between 11 and 16, because between 11 and 12, it's only 2 shots, and after 14, it's 3 shots. But we can still give women this vaccination after the normal window of vaccination, as long as she is tested negative twice for HPV. Even if she's tested positive previously, she can now take it even after being tested positive, as long as she's had 2 negative HPV tests. So that's really important to know, because previously, especially in the United States, there was a 26-year-old cutoff. That cutoff no longer exists. So it's a means of prevention for even the older populations that didn't get it previously. So these are just a couple of facts about HPV that I'm sure we all know, but the whole point is that HPV vaccination is to prevent a more serious illness. And it's an illness that most women don't even know they have. Women walk around asymptomatic until they don't. And then if we're not testing regularly, especially with the present United States guidelines that say if you have a normal pap smear year 1, then you don't need another one for 3 to 5 years, depending on your age. And that number gets higher as you get older. And we have an entire generation in the United States that didn't qualify for the HPV vaccination that are now qualified. So we're hoping to get the numbers down. These are the different HPV types that can cause cancer or warts, which either way are quite uncomfortable and causes a lot of pain to females. These are the contradictions and precautions that you're supposed to stipulate to your patients in trying to get them to take the vaccine. Right now, we're in a anti-vax kind of community. So can you guys give me some examples on how you would try to support a positive decision and acceptance of the vaccine for a patient who might not be sure or said no previously?
Well, you would just educate them on what the results would be if they didn't get it.
Sometimes explaining the mechanism of action of the vaccine can help.
Okay, so those two are really good ideas. Also, addressing the stigma. So knowing who you're talking to. So if you're talking to a Muslim woman who just brought her daughter or her son in, who might think that by giving my child this vaccine, I'm basically consenting them to have sex. How do you address that?
Not very successfully.
Well, I mean, there are ways to address the cultural and religious aspects that we do have to consider when we're having these conversations with our patients. So for any, very conservative religious family, we do have to talk about the fact that this vaccine doesn't give her consent to have sex. It doesn't protect her from all the other diseases. And as a matter of fact, we don't even have to tell her, the minor, that this is something that has anything to do with sex. We can just say this is a vaccine to protect them from cancer, which is really what the vaccine is. It just so happens that this virus is caught by having intimacy. So you then remove the stigma from the parent, allowing them to be a little bit more open-minded. Does that make kind of sense to everybody?
Yes.
Sense, yep. Yeah.
No, what's your feedback, Dr. Stein?
Well, it's a dancing act with families. I mean, they may not even have enough time, but I think saying that, one thing you can say, it protects her from rape. If she gets raped and there's a disease there, but this is the art of medicine, basically, what you're talking about. And it has a lot to do with you and how you're comfortable and what you can present. I had a patient with ADD who wouldn't take the medicine during Ramadan. Things get in the way. I think your suggestion about cancer is wonderful.
Yeah, I mean, that's kind of the idea of this whole presentation, is to kind of, let's discuss, ways that we can help each other to better communicate with our patients, because sometimes it's something as simple as we just didn't get out of our own heads to be able to figure out how to better communicate. So yeah, that's kind of the underlining objective of today. So I really hope you guys continue to engage. So here's I
would tie that together with all the other vaccinations they have to get,
Yes, exactly. And also just addressing all of the gorillas and elephants in the room. Giorgio, I don't know if you guys have the same vaccination stigma in Italy as there has been here in the United States. That was all started by what has since and long been discredited report about the connection between vaccinations and autism. And because social media is what it is, it has continuously resurfaced and kept perpetuating this fear. So 9 times out of 10, you spend most of your time trying to convince them of what is not true. And as physicians, when we are told that we're on a timetable, sometimes it can be frustrating, and you just kind of want to get to the point and get them to understand and just say yes. But there's ways that we can finesse it. And as Dr. Stein so eloquently said, it's the art. This is the art of medicine. This is the part that's the art. But these are 6 reasons why, you should get the HPV. Things that we all know, and we probably have told patients over and over again, but use these 6 points and then augment them to fit the interaction that you have with your patient, because sometimes there'll be cultural differences, religious differences, community belief differences, and you have to understand how those all play a part in their health behavior. And, always inviting, one of the best parts about my experience with Dr. Bernard and this practice is watching how people brought their loved ones. And it was very open for the loved ones to participate in the history giving, as well as participate in describing symptoms, because we don't always see ourselves the way the rest of the world sees us. And having that extra opinion or insight does help us. And the same thing can be said about the influence and confounding factors that affect our patients' behavior. And we need to understand that and kind of consider that. This is from John Hopkins. These are the reasons why parents refuse. So this was from 2006 and 2010. So I have a couple of questions here. How would you guys address some of these reasons? Can you see them, or do you need me to read them out loud?
Would you please?
Okay, so the first one says for girls, 23% said parents refuse due to safety. 20% lack of necessity, 13% lack of knowledge, and this is just for girls. 10% abstinence of physician recommendation, and then 10% assumed not sexually active. And then for boys, there was a gender necessity, which I thought was interesting because for all intents and purposes, I know I've convinced a couple of parents that had boys, because I am a mother of 2 boys as well, is that men do get HPV. HPV is transmitted from a man to a woman. So if your son is not circumcised, he's actually carrying it. So why not, protect him from his risk of getting penile cancer, as well as decrease the spread of the virus altogether? When you put it in that type of terminology, it then makes sense why this came up, but also how we can debunk it as a group, right? So that's what I mean. Like, how would you address some of these issues, whether it's parents of girls or parents of boys? Let's hear some of your comments.
Well, there's a lot of
so sorry about the dogs.
A lot of cervical cancer in this country. Let's see, 33,000 cancer diagnoses last year. And last year, cervical cancer killed 311,000 women. No, it's tough. How are you going to, when you talk about cervix to families, it's going to be a tough one.
Yes, but when you're talking to parents of boys, you don't talk about cervix. You talk about the penile cancer. You talk about the stenosis of the urethra that can happen. You also consider the fact of, depending on who you're talking to and what their cultural background is and what their community beliefs are, discuss how they could be affecting their community as a whole. For example, disproportionately, minority women die more readily from cervical cancer. So if you're talking to a Hispanic, Black, or Asian family, maybe you bring that up. Or if you're talking to a family that doesn't circumcise their sons, and in understanding that, you can help them understand how they would be making a positive effect on their community. So this is how you change the conversation, but keep it within what it's going to short-term and long-term effects.
In the Islamic culture, I think you talk to the imam first. You work with the guy in charge. They respect him much more than they respect you. Absolutely.
Well, that may be true. And I would agree with that if we were talking about a community-based program. But if you're just dealing with a patient for the first time, these are just some ways that you can deal with them on a one-to-one. If you see them once and probably never see them again, and help them understand why this vaccine is so important. What about you, Dr. Hayes? How would you pick one of these and let me know what you would say to kind of.
Well, I've always had great success in talking to people who have actually experienced these things, and not necessarily medical providers, just someone who has basically benefited from the vaccine, from the community that they come from. I think that would be effective.
Yeah, absolutely. Because for every one man that gets that vaccine, they're saving at least 4 to 6 women's cervixes. I mean, if that's how you want to put it, that's the way. Like, I did research when I was in Barbados. I did a case study on the prevalence of HPV in countries that have high populations of circumcision versus populations that don't have high circumcision rates. And the populations with low circumcision rates or no circumcision rates, especially in the Caribbean, which is where I was doing most of the research, their rates of cervical cancer were substantially higher above the global average. So there's something to be said about getting rid of this gender necessity part of this conversation, right? Yes. And just something, food for thought. Just figured I'd bring it up. Clearly, I'm biased. I like women's health a lot. This is the timeline in the United States for vaccination. So if they're over 14, so I stand corrected, I said 11, it's 14, then it's 3 shots. And then after 15, it's 3 shots. But as you can see, now this number is 45, where several years ago, it was 26 when the shot first came out. So all you got to do is make sure your patient, especially if you are in OB or doing, family medicine, if the patient just delivered and previously tested positive for HPV and has delivered within 18 months, I say retest her, because you might be able to get her that vaccine before she gets reinfected. So these are, because for whatever reason, it's been found that after delivery, because of the whole restart and shedding of the entire system, women tend to not be positive anymore. So you then have the opportunity to give them the vaccine and protect that population. So another reason why to understand and be able to communicate appropriately with your patients. So what if your patient says, I need some time to think about it? What do you do?
Give them a few YouTube channels to look at.
Give them some pamphlets to look at. Okay, yeah.
Or videos. There are many videos out there.
CDC has tons of videos. I always love to give out the CDC videos, because although now in the United States, CDC videos are a little shaky. So I tried Planned Parenthood. March of Dimes also has videos. You can even go to the pharmaceutical company themselves, and they tend to have videos as well. Sometimes they're more commercially, but these are all the different ways that you can provide them with information. Also, there's medical education websites like Osmosis on YouTube that also has really good videos on the topic of HPV vaccination and cervical cancer, so that if they need more time to view it and maybe get some more understanding, those are also options. Also free on YouTube, doesn't cost the patient anything. So how long do you normally give a patient to contemplate whether they want to come back for it? Do you set up a follow-up visit right then and there, or do you call back? What would be your practices?
If you're practicing neurology or family medicine and you have so much to do, I'm not sure you have time in reality to have them come back for discussion. I really don't. I mean, these people are all terribly busy. And I just think the reality is very difficult.
I thought the same thing. Dr. Stein, and did my family medicine rotation, and this woman has her own practice. And the way she handled contemplation is that she would immediately set them up for an appointment a week later. And during that appointment, it was, let's rediscuss the shot. Let's give you some shots. So if this is for example, this is flu season. And so she would say, oh, we'll give you the COVID this week. While you think about HPV, we'll hold off on the flu shot. So they have a reason to come back. And 2, you have another opportunity to discuss the HPV vaccination. So there's ways that we as physicians can do it. And yes, it does make our practices more busy, but it is all about making our patients healthier, or at least that's my belief, or I try. So that's one way. Or, you have nurse practitioner or office manager follow up with them a week later or a couple of days later to see if they want to reset the appointment for the HPV vaccination.
How about give them the information before they come in for their appointment? So that way they're well informed, and then they can go ahead and get the shot.
So that goes back to Dr. Stein's point. People are busy. If we give that to them, the likelihood, at least for this family medicine practice, they tried that idea. They had exactly your idea and they tried it. Patients weren't reading them.
Ah.
It wasn't until they were in front of the doctor or in front of the MP that and kind of faced with the decision, did they ask the questions. So then you can give them the appropriate information, they can read it, and then you follow up. And like Dr. Stein said, most doctors don't have time to sit there and call their patients back, but they have office managers, they have MPs that can do that, or follow up, email that you send out as a timer, which you can do, which I didn't even know you could, but this doctor showed me that you could, and that's how she does it.
Let me give you some lousy feedback, okay?
Mm-hmm.
Okay, there, 1 million Americans have died from COVID, and here you are peddling their vaccine. Why aren't you putting your energy into saving more lives with COVID? I mean, I understand what you're saying, but the big picture in my head is, okay, that's not as important as saving 1 million lives. So I'm going to challenge you with that.
And I completely understand what you're saying. COVID did take more lives than World War I, II, and the Vietnam War. I do understand that. And that is an important vaccine to get, which is also important to discuss with your patients. But this conversation can be applied to any vaccine. So it's not this, I used HPV as an example, but to get our patients to comply with the vaccination regulations is actually a lot harder than people would like to believe. And it's because there's so much misinformation. And my presentation here is really to discuss how we can better engage our patients, provide them with the information, what we should do as physicians to keep the conversation open and move them in a direction of vaccination. Because you could apply that to chickenpox, you could apply this conversation to MMR, you can apply this conversation to the flu shot, you can apply this conversation to the COVID shot. This conversation can be applied to any vaccination schedule that you can think of. This is just, I just happen to pick HPV.
Well, but basically you're talking about a generic approach for all these required vaccinations. I mean, what do you do with
it? Might not be, I don't think it's necessarily generic, because you have to adjust based on who you're talking to, because I'm not giving you a blanket, I'm not giving you bullet points as to exactly what to say. I'm saying, here are some bullet points to consider when you're talking to your patient. Here are some resources that you can use, things to think about when you're talking to patients, because the conversation isn't going to be the same with every patient. I have yet to have a generic conversation with a patient, ever.
No, the principles of persuading somebody. In reality, the nurse practitioner, for example, in diabetes, the nurse practitioner does most of the teaching. I don't think the doctors have much time. I'm just saying, for reality of life, of practice, people are seeing 15 minutes. They're lucky to be seen 15 minutes at a time. And the American medical system is horrible. And you are wonderfully idealistic. I appreciate that. But the question is, how do you make it work in the real world? You have a wonderful doctor, but that's one. I sound like I'm being really pessimistic, but I'm trying to be realistic.
Well, I completely understand your opinion. And I realize that, yes, the system is very broken, and the system is exactly what it is, where if you work for a macro system and you work within the confines of the 15 minutes and you're supposed to see 30 patients a day. And
right, yeah.
I understand that, but there's ways that you can learn how to work around it. And personally, for me, I plan on just doing residency and opening up a private practice. So I have no intention to be spending just 15 minutes with my patients. More importantly, I'm not under the impression that I can't get someone to talk to me or listen to me if I approach them in a manner that is at their level rather than at them.
Let me give you some more painful information. Private practice, an OB spends over $100,000 for malpractice insurance. You have to pay for rent and staff. And the question is, you have to then figure out how many patients do I have to see to stay alive. I mean, it's painful reality, unless you work for a place like Kaiser or something where they take care of everything. But in private practice, it's hard to afford all the dollars to have plenty of time to talk to patients. I'm just saying that's the reality. It's painful, it's terrible. So the best you can do, I think, is to get a physician assistant, somebody who doesn't cost as much as your time to do that kind of work. Or you can say,
I agree that that person does need to exist within my system, thinking, but at the same token, I still need to be able to communicate with my patients. And they still need to trust me in an effort to make a decision, because bottom line is, yeah, they're going to trust my NP too. But when we're talking about a football team, I'm the quarterback. I'm the one that they're going to end up suing first. So if I don't have a rapport with them, whether it's for 15 minutes or 15 seconds, it doesn't matter what I say.
What you see in Dr. Bernard does not take a salary. Okay? If he did, he probably he couldn't do what he's doing. Okay? His practice of medicine almost as a hobby. Okay? So you can't, as wonderful as it is, you can't take that as an example of what it has to be.
Well, I wasn't using his practice as an example, but I appreciate your input.
It's painful, it's really painful. Did I show you the video from Dr. Daria about, he was talking about his practice in IMG?
Yes, and we also agreed to disagree on some of some of the points that he was bringing up. So while I appreciate the feedback and I appreciate the fact that there is a dying breed within the United States of private practice, it is a choice. And it's a choice that everyone has to make on their own terms, in their own way.
It's a wonderful choice. It's a great way of practicing medicine. Just make sure it works for you, for everybody. It doesn't, the question is, how do you make it work in terms of staying alive, paying insurance, all that kind of stuff?
So, Dr. Stein, in an effort to not digress too far from the topic at hand of trans theoretical model of change.
Okay, good.
So once you get the patient into contemplation and you call them back, or they've come back to see you, you reintroduce the idea. And depending on how willing or interested the conversation is back to you, you can determine whether or not they're in one of these steps, which you basically want to make sure that your patient is in some sort of preparation step, so that they're more willing, they're more pliable, which means you would have had to give them as much information as possible, giving them time to think about it for themselves, talk to their own people, talk to their own family, come back with you with questions, and allow them the opportunity to ask them, and give them the 30 seconds or less that it takes to let them ask and you answer. And then re-ask the question. And 9 times out of 10, they'll be ready for some sort of action. So these are just some more updates on prevention. Again, the criteria that I stated before in reference to the fact that it's not just for young adults anymore, and is now goes up to 45, and the 2 negative HPV, they're allowed to then get the vaccine after that. So whether or not to choose the 9 or 4, it just depends. I think right now in the United States, it's only 9. I think 4 isn't even an option anymore. And all insurances in the United States cover it, from Medicaid to Medicare to private insurances. It doesn't cost the patient anything. It's part of even if it's outside of the vaccination window, meaning they're over the age of 18, it's still fully covered by their insurance. Mm-hmm. So if the patient continues to say, no, thank you, what do you do? Do you just let it go, or do you keep pressing it? What do you guys think?
I think you should provide them with as much information as you possibly can, because you can't make anybody do anything. So just provide them with as much information as you can and let them read it at their leisure and let them make the decision.
Right. So you just give them the time, reintroduce the information you gave to them before, you let them take it home. And then when you see them in a year, guess what? they got to get flu shot, COVID shot, and everything else all over again, you can bring up the same vaccinations.
Yes.
So sometimes it's just repetitive. I've read a couple of papers that say human behavior takes 3 times of being asked before they'll just say yes.
You're right.
It might take you 3 years, or 3 visits, depending on how often you see that patient. But you'll be more successful in vaccination compliance.
Sure.
I appreciate your exuberance, and it makes a lot of sense. I know that when I've been talking to people who do world medicine, go to other countries, their job is training they don't treat the patient, they train other people to see the patient, nurse practitioners, men in the community to carry the message. And so the issue really is, your ideas are fantastic, but how do you get it done? One thing might be to go to the drug company and ask them to pay for an advertising campaign. I mean, how do you get your ideas out there and stay alive? That's really the only thing I'm saying.
Okay. Well, one of the ways is I'm a professor of health communication. So that is one way I'm doing it, by educating other physicians and nurses and clinicians on how to have this conversation. At least every semester for the last 2 years, I've been doing that. So there is an actual generation of nurses and PAs that have learned how to make this communication. I've also been working with osmosis for the last 3 years, and I also have this conversation with doctors around the world, having this same conversation. So it's a matter of planting a seed, allowing people to take away what they want, and understanding that application isn't overnight. Turnaround doesn't happen tomorrow. It's a matter of understanding that change, especially in a system is cog-wheeled and rusty as the medical system is that we work in.
Yep.
You have to appreciate the fact that change comes with one person at a time. Because the way that our educational system for medicine is that when I become a doctor, I'll teach another doctor. I'll teach 4 more doctors. Those 4 doctors are going to teach 4 more doctors. So yeah, I might not see this communication change tomorrow. I might not even see it in my lifetime. But I know that they're going to be doctors that talk better to their patients.
Well, I would kick you upstairs and make you the CEO of a program that reaches out to everybody. I'm just concerned about your time and your income. That's really the issue. I mean, I love your zeal. It makes a lot of sense. And how do you make it work? How do you expand your ideas and teach other people that?
So I actually am in the process of creating a coalition of African-American physicians that we all went to medical school together. I took a pause to take care of my children and family and my post-traumatic stress after being in a hurricane. But they're all doctors now. And I'm actually working with all of them to create a co-op of physicians that'll function in New York City, North Carolina, and Tennessee. And I have property in all of those areas. And there's grants in each of those states, specifically North Carolina and Tennessee, because they're rural and they're paying doctors to build stuff because they don't have enough facilities. So that's how you create, you make a long plan. I've been planning this since my first year of medical school when I was inspired by the notion. So it's not, I appreciate your pessimism, and your devil advocate, but please bear in mind, I've been thinking and planning and plotting for years.
It's not pessimism. I think it's a great idea, but the really issue is implementation. And you need a full-time salary from a foundation to do this. That's all I'm saying. It's practice is very difficult. So I'm just, your ideas are wonderful. How do we get them implemented? One by one in office is one way you could do it. I understand that. But I'm not pessimistic, I'm realistic, okay? I want you to
agree to disagree.
Okay, of course you do. You always do.
Yes.
Okay. Yeah.
So here are some other reasons why patients will say no is the provider's disposition.
Yep.
The provider's mannerisms, their personality, their social environment. This is the reason why I always tell my fellow medical students, we are not competing, because the patients that are going to see me are not the same patients that are going to see you. The patients that like me are not going to like you. It's just one of those things. So also where you're practicing is also going to change certain factors that you have to consider. And then also, you know, community and health behaviors are also going to be influential factors that you need to understand while you're working wherever you're working, whether in a residency program, own practice, macro system practice. You just got to know who your population is and be able to present yourself in a manner that will allow them and you to be able to communicate without a hierarchy in the room. Because no patient wants to be talked down to or talked at.
The best way is to tell people, I gave it to my kids and I feel good about it. The more you can own it yourself, the more successful it'll be with the patient. As you say, it's the attitude. The attitude can't be, you can't make it up. It has to come from yourself. And that's what many ways how you convince patients. You know, how does a fat person tell a patient to go on a diet? It doesn't work that well. So anything you can do on your personal experience and push that will be very helpful.
I agree. Absolutely.
Then you also avoid lawsuits.
Exactly.
Because if you have a good relationship with your patient, they're less likely to sue you.
Thank you. Thank you, Dr. Hayes. I appreciate you. So these are some of the counter health marketing strategies that Dr. Stein actually brought up, which is engaging social media. So like just being one of the many doctors on TikTok that is trying to revert the misinformation that's been thrown up everywhere. Partnering with local schools to create a community health program, working with other providers to see how they're, you know, that have good vaccination compliance. What are they doing? What's so different? There's also a lot of offices, especially in the macro system based offices, they have these TVs that run loops of like different health videos, and you can work with different health producers and create a video of your own. But these are, and then wait, the most important part is let the patient come to you as well. Give them time. Time is not, you know, for this particular vaccine, time is not the problem. For others, time is the problem. So a lot of follow-up needs to be done. So here are some other countermeasures for anti-vaccination. So people worry about the autism, the environmental factors. Is this really going to increase my risk of getting anything? Is it really going to protect me? You know, you're saying that there's this, and, you know, so sometimes throwing too many words at the patient or too many numbers and too many descriptions will lead to them not really understanding anything at all and just pushing away. So again, going back to making sure you're speaking with them, not at them or above them.
Okay.
Oh, sorry, this is a repeat slide. Okay, so that was everything. These are my references. Do you guys have any other questions?
No, thank you.
I enjoyed your presentation.
Thank you.
I like the interaction. Yeah.
I prefer not to just